for patients who are transplant eligible, once they've had their transplant, maintenance therapy is the standard. Most patients get lenalidomide as maintenance therapy. I also feel that it is probably not enough to do lenalidomide alone for high-risk patients. So patients who have deletion of 17p, have other chromosomal abnormalities like 14, 1420, 1416, I think could benefit by the addition of a proteasome inhibitor to the mix. So therein we are using Velcade twice monthly with lenalidomide as maintenance therapy, though there is no randomized data to suggest that dual maintenance is better. There was a trial done by the group at Emory looking at extended period of VRD post-transplant that showed that there were fairly impressive rates of PFS. In the post-transplant setting, another thing that has been explored is the use of consolidation. The use of consolidation remains experimental. In a large US study, the Stamina study, it did not seem to add to the PFS, nor did the use of tandem transplantation. However, another study done in Europe by the EMN group did show an improvement in PFS, both by the addition of a second transplant and by the use of consolidation therapy. The contradictory results of these two studies may be predicated on the kind of regimens that were used pre-transplant. So I think that it remains a matter of conjecture as to why these divergent results were produced. So I think that at least in most institutions, consolidation is not a routine part of management. However, if patients don't achieve a very good partial response, a lot of investigators and treating physicians do consider on a case-by-case basis the use of consolidation to deepen the response post-transplant.